Hello, everyone. My name is Paige Kuiper, and I am currently a DNP family nurse practitioner student at Penn State. For my capstone, I am working on a quality improvement project to increase exclusive breastfeeding rates here at Mount Nittany. Thank you for taking the time to watch this presentation and for participating in this quality improvement project. So, while many different feeding types and practices occur throughout the world, the American Academy of Pediatrics recommends exclusive breast milk feeding for at least 6 months, with supplemental breast milk feeding up to and beyond 2 years of age. Exclusive breastfeeding aids in protecting both the mother and the infant from a variety of diseases and conditions, both temporarily at the point of breast milk delivery and throughout the future life of the mother and the infant. When formula supplementation occurs in the setting of breast milk feeding, the infant and mother do not receive the full and lasting effects of breastfeeding, and even a brief period of formula supplementation in the postnatal hospital stay can impact the duration of further breast milk feeding up to 12 months beyond the original time of supplementation, and also affects the exclusivity of breastfeeding and whether or not additional formula supplementation is used 2 months after the initial supplementation. Within the literature, nurses have been shown to play a significant role in promoting and increasing the number of infants who are exclusively breastfed. Nurse education is a quality improvement initiative that increases the skills and self efficacy of the nurse so that women get the support they need to be able to exclusively breastfeed their infant. Infants who receive breast milk receive a variety of protection from a variety of conditions, including respiratory tract infections, persistent diarrhea, otitis media, asthma, eczema, Crohn's disease, ulcerative colitis, type 1 and 2 diabetes, and leukemia, along with sudden infant death syndrome, allergen development, and obesity. Mothers also receive a number of protective effects from breast milk feeding. Temporary protection includes uterine involution, hemorrhaging, and infections. Lasting benefits also include increased protection from breast, ovarian, thyroid, and endometrial cancers, along with diabetes, osteoporosis, hypertension, cardiovascular disease, metabolic syndrome, Alzheimer's disease, and multiple sclerosis. While there are physical effects that the mother and infant are protected against, there are also a number of mental health benefits as well. Infants who received exclusive breast milk feeding were found to have higher IQ scores and protection from other neurological based diseases, including ADHD. Mothers who breastfed were noted to have increased levels of against postpartum depression, anxiety, bipolar disorder, and schizophrenia. While any breastfeeding does aid in the protection from diseases, the more breastfeeding that is performed by the mother, the longer and the more significant the protection the mother and the infant both receive as a result of the sustained and exclusive breast milk feeding. Formula supplementation can occur for a variety of reasons. This can be due to maternal preference, lactation issues, social issues, medical staff preferences. And while it is difficult to characterize the complex nature of why exactly an infant ends up getting supplemented with formula, it is well evidenced in the literature that the nurse within the postnatal period plays a large role in ensuring the mother gets set up for success for within the hospital and beyond the stay. Support and encouragement from the hospital staff is extremely influential, and nurses play a large role in whether or not the final call gets made to supplement the infant with formula or not. A nurse's own experience plays a large role in her own motivation to support the mother infant diet and breastfeeding, and the skill set they possess to be able to help the mother be able to effectively problem solve common breastfeeding complications. Unfortunately, nursing schools lack consistent and comprehensive lactation education, leaving many nurses who do not have their own personal knowledge and skill training to provide in depth knowledge to mothers regarding exclusive breastfeeding, its importance, and key ways to initiate and sustain it. Within the United States, there is a large number of women who desire to initiate breastfeeding, yet the number of women who are able to exclusively breastfeed without supplementation conversely is falling. It is recommended that less than 14% of infants receive formula supplementation within their first 2 days of life. Here at Mount Nittany, a recent data point extracted from 2023 showed as many as 43% of infants received formula supplementation during their hospital stay. Breastfeeding is an incredible source of nutrients for both mothers and babies as they progress through infancy and into toddlerhood. Breast milk is easily digested by the infant, has numerous health benefits, economic benefits, and mental health benefits, as previously mentioned. This is a great demonstration that teaches us why exactly breast milk is different than formula. While formula is nutritionally sufficient for sustaining the life of a newborn, breast milk is filled with numerous live properties that directly shape the health and gut microbiome of the infant. Additionally, it contains hormones and antibodies that are specifically tailored to each individual baby that help control appetite regulation, mood, sleep, and overall development. This is a breakdown of the exact nutrient contents in human milk versus cow and goat milk. Human milk has the highest dose of lactose and a similar fat content to that of cow's milk. While similar in overall macronutrient breakdown, the overall composition of protein is greatly different in cows versus human milk. Casein is a type of protein that is difficult for the human gut to digest. The amount is significantly lower in human milk compared to cow's milk. Many infants who are breastfed but receive formula supplementation are at a high risk of developing cow's milk protein intolerance. Cow's milk protein intolerance is different than lactose intolerance, where the body does not produce sufficient levels of lactase. Cow's milk protein intolerance is when the baby has an immune response to the cow's milk protein found in formula and views it as an invader and one that needs to be expelled from the body. This reaction causes injury to the baby's digestive tract. For similar reasons, formula changes the gut microbiome of the breastfed infant in a negative way and alters the bacteria in the gut and intestinal pH. Even one bottle of formula can alter the human gut microbiome for a significant period of time. Further diving into the breakdown of human milk, it is commonly believed that mature milk simply comes in all at once. While it is actually an overall process of several days where mature milk begins the process of transitioning out of colostrum. Mature milk, commonly seen with engorgement in the first few days of life, is still filled with colostrum, and the breakdown is a mixture of that of colostrum and mature milk with a higher fat content. Additionally, as mature milk develops, there is a difference between the foremilk and hindmilk, which is why we want the baby not only frequently latching, but latching for a sustained period of time. When pumping until the breasts are empty so that the infant receives the higher fat content in the hindmilk. Here are more benefits of colostrum, including additional amounts of protection, including higher amounts of vitamin A, along with growth factors that aid in intestinal maturity. Colostrum is also purgative, which means it is similar to a laxative and aids in clearing meconium and preventing jaundice. One of the biggest benefits of breast milk is the protection against diarrheal illnesses. This is a breakdown as to why breast milk only is essential in protecting the infant as opposed to both the mixture of breast milk and formula, as demonstrated within the third column. The psychological benefits of breastfeeding are often overlooked, but incredibly important. Continuous and frequent nipple stimulation releases appropriate amounts of oxytocin, which helps control the physiological bond between the mother and infant. Additionally, the literature has demonstrated that breastfed babies have increased ratios of gray to white matter in their brains, which aids in neurological connections and intelligence. So next, let's talk about how the infant latches at the breast. This is a great demonstration as to how the nipple actually looks inside of the mouth. The nipple itself should be hitting the soft palate of the mouth compared to the hard palate. As demonstrated in the black coloring of the drawing of the infant's mouth, this is breast tissue, which is soft and flexible and with minimal nerve endings compared to the bulk of the nipple itself. A good latch should be determined by the latch not being extraordinarily painful, the baby's chin touching the breast, the lips turning out, the tongue cupping the nipple, and stimulating the breast tissue, not just the nipple itself. The breast tissue here is key, as we want the tongue to produce waves on the areola that stimulate the flow of breast milk onto the nipple. The tongue is a continuation of peristalsis and is a wave-like in nature, not just simply moving up and down. This is very different than sucking on an artificial bottle nipple or pacifier and requires different facial movements and tongue and jaw movements that are coordinating together. Again, here we see a comparison between a good latch and a bad latch. The infant on the right will produce a painful latch as the nipple is on the hard palate and not on the soft palate. And one of the main determinants of this type of latch that we see is how much areola is actually being taken into the mouth and if the chin is touching the breast itself, as demonstrated in the left side of the picture or number 1. As seen in picture 2, compared to 1, we can see here the nipple is being flexible and being capable of being latched onto with general ease, compared to in picture 1, where the nipple is inverted and an infant may have trouble taking the small portion of the nipple that is visibly seen back to the soft palate of the mouth. In this case, the mother may be taught how to evert the nipple prior to latching and may need additional interventions to ensure the nipple is extended for latching. This is an external view, or what we can see when determining if the latch is ideal. This is a great picture of what a nipple might look like if the latch is not taken back to the soft palate and the infant is just sucking on the nipple from the hard palate. As you can see, the nipple is deformed and it looks like there's kind of a line over top of it, which you can see is from the hard palate itself, and it's not being properly formed into the soft palate. Other problems with infant latches that we can see here are tongue and lip ties. Tongue or lip ties are oftentimes manifested as colic or gassiness from an improper latch. And when the infant is unable to perform coordinated peristalsis of the tongue and create a vacuum seal with its lips and tongue, then a negative pressure environment is not made, and excessive air enters into the oral cavity and is swallowed. This excessive air causes gassiness, belching, and pain for the infant. Nipples come in so many shapes and forms. However, all of these nipples are capable of breastfeeding effectively. Some just may pose more challenges to getting the process started compared to others. Here we have more information on what the mother and infant may feel if there is a poor latch. Two major categories that I would like to highlight are that the baby feeds frequently for a long time, and baby cries a lot and feels unsatisfied. As a mother-baby nurse, you all know that the importance of helping first-time breastfeeding moms is incredibly essential to creating the foundation of their breastfeeding journey. A lot of times, mothers with limited prenatal breastfeeding education are told the infant should feed every 2 to 3 hours for 10 to 15 minutes per side. However, as nurses with medical and breastfeeding experience, we oftentimes forget to also lay out that expectation for new mothers and that there is a wide range of normal. The baby may feed for 15 minutes on one side at a time every hour and a half, or more frequently, which occurs especially at night within that second night of the hospital stay. It is so important that the expectations are laid out and that it's okay to have frequent feedings that may be longer, and that this is not always a determinant as to how much milk the infant is actually receiving. A lot of times there's uncertainty of, am I doing this right? Is my baby okay with just my milk? Am I enough for my baby? That triggers the mother to wanting to supplement. However, when expectations are laid out that yes, there is a wide range of normal, your baby is doing well on breast milk, and highlighting the importance of not supplementing in the hospital is when we are truly supporting the mother to be able to exclusively breastfeed. Prelacteal feeds, or what we commonly refer to as formula supplementation, is a common practice in the United States, but one that poses the risk of discontinuation of early breastfeeding along with medical complications. These feeds occur for a variety of reasons, and oftentimes are either for a medical reason or at the request of an uncertain and inexperienced mother. Colostrum is an essential nutritional source that promotes sustained gut microbiome and immunological health. When formula is replacing these feeds or being added onto a feed, the baby is getting less breast milk. Baby will suckle less, stimulate the breast less frequently, promote nipple confusion, which can lead to a bad latch after a good latch has already been produced, and make the transition to breast milk from colostrum delayed and less successful. The evidence within the literature has shown that even a brief period of formula supplementation, even just one bottle, directly impacts whether or not the infant is breastfed at both 6 months and even 12 months beyond the original supplementation. This period of vulnerability in the hospital period can directly impact the infant's health into adulthood and well beyond that first initial time of supplementation. One of the most common reasons for formula supplementation is perceived insufficiency of milk. However, there may actually be limited supplies where the would be medically supplemented if there is little skin to skin, if breastfeeding initiation is delayed due to medical interventions, or if there's a poor sucking attachment and ineffective suckling due to latching issues that were never recognized to begin with. For these reasons, milk supply may actually be inefficient, and we should look for cues in malnutrition and weight progression with wet diapers. One way to help the infant try to latch before they are too hungry and get frustrated at a difficult latch is to watch for early feeding cues prior to crying. As a mother-baby nurse, you are all probably very well aware of hunger cues. However, it is important to carry on this wisdom to the patient so that they are aware of these cues themselves and can recognize when to latch on to their baby before the infant gets too fussy. As a result of the following, our early feeding cues, the breast milk transitions sooner, the baby will gain more weight, the mother will have less difficulty with engorgement, and breastfeeding is more easily established. As part of the 10 steps to successful breastfeeding, encouraging rooming in is an essential aspect of ensuring the baby is fed and responded to appropriately. One way to promote rooming in is to simply not bring up the option of taking the infant to the nursery. However, when unavoidable, explain to the mother that the practice of not rooming in is not recommended as it can interfere with breastfeeding, affect infant weight gain, and ultimately does not really change the amount or quality of sleep the mother receives. Additionally, the baby itself will experience less quiet sleep and is more likely to cry frequently. While it is important for mothers to sleep, it is also more important that when the mother leaves the hospital, that she is set up with expectations of nightly feedings and wake times. She should be encouraged that she is strong and capable of doing it herself. Additionally, educating mom on why the infant feeds throughout the night and the importance of around-the-clock infant feeding is essential for building and sustaining a milk supply. By reinforcing, encouraging, and supporting the mother, by allowing her to see that she is doing a good job and that the baby will be responded to better in the room with her, and that she is doing exactly what she needs to do, helps support the mother-infant dyad. Another key step in the 10 steps to successful breastfeeding is limiting pacifier use. Pacifiers have been proven to delay breastfeeding, cause nipple confusion, and have many other complications. Pacifiers, on the other hand, can be a great tool if they are used in the right way, but the postnatal hospital period is not the right setting for them to be used in. Pacifiers should be used after breastfeeding has already been established and the mother's milk supply is established. They should be used in the setting to soothe the baby who is already satisfied with milk after an infant has received milk or has reflux, or to soothe the baby to sleep, which can secondarily prevent SIDS. However, again, there is limited appropriate uses in the hospital period for an infant to be born right after an infant is born for a pacifier to be used. Another essential step in the 10 steps to successful breastfeeding are to set the mother up for success beyond their hospital stay. Encourage community resources such as lactation consultants and mother-to-mother support groups such as La Leche League. Encourage mothers with limited breastfeeding support from their family to find a personal friend that is there for them with questions and for support. Having a support system is essential, and it starts with the tools the mother is properly given in the hospital. As we already spoke about before, the way the mother is spoken to and the support that she perceives from nurses and how she experiences her nursing support is extremely influential in how she will feed her baby both in the hospital and beyond her stay. When mothers are frustrated, especially at night with excessive crying, offering your support and compassion is essential in helping the baby. If there is nothing physiologically wrong with the infant after an assessment, praise the mother for doing a good job. Educate her on why the infant may be crying and give practical help to the mother and infant. However, try at all costs to avoid leaving the infant out of the room and giving pacifiers. Again, lay out the expectations that while yes, it may not be the time for the infant to feed according to the clock, they may still be hungry, want to be held and soothed, and want the mother's nipple for comfort. Additionally, assess the baby for gassiness and watch for the baby's latch and for effective feeding. Here is a recap of the 10 steps to successful breastfeeding. The 10 steps to successful breastfeeding are guidelines created by the World Health Organization as part of the Baby Friendly Hospital Initiative to support exclusive breastfeeding in the postnatal hospital period. Mount Nittany Health is currently working towards becoming Keystone 10 certified, which is a similar certification using the 10 steps to successful breastfeeding. Within these, steps 1 and 2 are facility driven. However, as a nurse in step 1, it is essential to not give out formula samples to patients unless they are specifically requested to. Remember, one bottle has the chance to hinder a breastfeeding journey up to 12 months beyond that time of the bottle. In step 1B, at Mount Nittany, you have a policy titled Feeding the Full-Term Infant that is available for feeding protocols and guidelines. In step 2, because the number of infants exclusively breastfed is a quality factor that examines facility practices, the hospital keeps track of infant feeding statistics to monitor how progress is being made and how the infant is being fed. By completing this educational session, you are all working to continuing your knowledge on breastfeeding competence and skills. And while this step is outside of the nurse's role, it is important to recognize that Jess has helped set up an incredible breastfeeding education program for families for both prenatal support and outside of the hospital. Here is where we all will make an incredible impact. In step 4, we want all infants to have skin-to-skin contact within 1 hour of birth, or as soon as possible for those mothers with varying medical interventions. In step 5, we want to help all mothers manage breastfeeding complications. In step 6, we want to support the mother to exclusively breastfeed by avoiding formula supplementation unless medically indicated. In step 7, we want to encourage the infant to stay in the room with mom at all times. In step 8, we want to teach the mother what we know about infant feeding cues. In step 9, we want to avoid giving out pacifiers and discourage their use. And in step 10, we want to ensure that women have support outside of the hospital and that there are many ways for support to be offered, including help from a provider's office, community support groups, and external lactation consultation. Thank you all for viewing this presentation. If you have any questions, please don't hesitate to contact me at the email listed right below. And as a note, slides 1 and 6 to 42 were obtained from the Baby Friendly Hospital Initiative Maternity Staff Training Guide presentations, which is funded by the World Health Organization. And here are further references used for the development of this presentation. Thank you all.